Hey everyone, welcome to this explainer. Today we are looking at an incredibly handy study guide from Mrs. Graham titled Crash Course on Incisions. Now, instead of just memorizing a dry list of 12 different cuts, we're going to look at this as a vivid spatial roadmap of the human body. And if you're training to be a surgical technologist, mastering this map, it's absolutely crucial. It is literally how you make that leap from just being a helpful assistant to being a true anticipatory partner in the OR.
Okay, let's dive into this. As Mrs. Graham says right at the start, hello, future surgical technologist. This material is made exactly for you. But why, right? Why is locking down these 12 specific incisions the ultimate secret? Well, think of it like this. In the operating room, the incision is a doorway. If you know which doorway the surgeon is opening, you instantly know what room of the body you're walking into. You know the organs, you know the landscape, and most importantly, you know exactly what retractors and sutures the surgeon is going to ask for, usually before they even say a single word. To make this super intuitive, we're using a top-down spatial approach today. We'll be covering 1. Chest and central incisions, 2. Upper abdomen access, 3. Lower abdomen and pelvis, and finally 4. The flank and back. All right, moving right into section 1, chest and central incisions, specifically the midline and sternum. We're starting dead center. So, the very first doorway on our map is the midline or median incision. This is your classic vertical cut right down the center of the abdomen, following the linea alba. And actually, this midline is kind of our geographical baseline for the whole abdomen. That linea alba is a fibrous band of connective tissue running down the stomach. And because it's connective tissue, it's relatively avascular, meaning it doesn't bleed very much. So for you as the tech, that means the surgeon is getting in fast and clean. The absolute best thing about the midline incision is its pure versatility. It is the absolute go-to for exploratory laparotomies or major abdominal trauma. Why? Because depending on how far you extend it, you can literally expose the entire peritoneal cavity. If a trauma patient rolls through the doors and nobody has a clue what's bleeding, they're using a midline. You've got to have a huge variety of tools ready on your Mayo stand because you could be looking at the stomach and liver up top or all the way down to the intestines, uterus, and bladder. Now, moving straight up the chest from there, we hit the vertical midline sternal, or what you'll usually hear called a median sternotomy. We're still dead center, but now we're cutting right through the sternum, the breastbone. The exposure you get here is just massive. This is the main doorway for critical open heart surgeries or thoracic aortic procedures. When you see a median sternotomy on the board, you already know you're bringing out the sternal saw, and you're prepping for immediate, high-stakes access to the heart, the lungs, and the great vessels. Okay, dropping down a bit, let's hit section 2. Upper abdominal access. We're covering the paramedian, subcostal, and chevron incisions. Check out the paramedian incision here. This is a vertical cut that runs parallel, just lateral to that midline anchor we talked about. Now, what's really fascinating here is how shifting just a couple of inches left or right completely rewrites your surgical setup. If they make a left paramedian cut, you're walking into the room with the stomach, pancreas, and spleen, so gastrectomies, splenectomies. But shift over to a right paramedian, boom, you're suddenly looking at the liver and gallbladder. It's the exact same style of cut, but totally different organs, which means a totally different instrument setup for you. Next up is the subcostal. Sub meaning below, costal meaning ribs. This one's an oblique or diagonal cut made right underneath the right rib margin. And that specific diagonal angle is what gives you perfect immediate exposure to the biliary tract. If you're setting up for an open cholecystectomy to take out a gallbladder, or maybe a liver biopsy, this is your doorway. The surgeon gets targeted, direct access right to the liver, gallbladder, and all those underlying biliary structures. Let's move to the next one and see how it builds on that concept, the chevron, also known as a bilateral subcostal. Picture that oblique subcostal cut, the Kocher incision, and just mirror it on the other side, joining them in the middle of the upper abdomen. It basically looks like a giant inverted V. Surgeons use this when they need truly massive upper abdominal exposure. Think liver transplants. As a tech, when you hear chevron, you know you're in for a long, complex case with maximum exposure of the liver, pancreas, and the whole biliary system. Moving down the map, we're at section 3, lower abdomen and pelvis. We'll look at the phalanstyle, the quadrants, and the inguinal incisions. All right, meet the phalanstyle, also known as the low transverse abdominal incision. And like the vertical cuts we started with, this one is curved and horizontal, sitting right above the pubic symphysis. You'll often hear it affectionately called the smile incision,
Because of its shape and placement, it is the absolute go-to for OB/GYN procedures, C-sections, hysterectomies, you name it. When the Pfannenstiel is the doorway, you know for sure you're dealing with the uterus, bladder, ovaries, and fallopian tubes, so get those specific pelvic retractors ready to go. Just like the upper abdomen, the lower abdomen is completely divided by left and right zones. Over on the right, you've got the oblique cut at McBurney's point. On the left, you've got the lower left quadrant or pararectal incision. So the crucial point here is knowing which lower digestive pathways map to which side. Right side at McBurney's, you're doing an open appendectomy, looking at the cecum and terminal ileum. Left side, you're prepping for a colostomy or sigmoid colon surgery, exposing that descending colon. Same horizontal level on the body, but knowing left from right literally changes your entire setup. Finishing up our lower abdominal map, we've got the inguinal incision. This is a horizontal or oblique cut down in the groin region. Mostly, this is used for inguinal hernia repairs. For a tech, this tells you exactly what superficial structures you'll be staring at first: the inguinal canal, the spermatic cord, and, obviously, the herniated tissue itself. You'll be handing up very specific retractors and different types of mesh for this one. Finally, Section 4, the flank and back. We are wrapping around the body now, entirely reorienting our map to the sides and back. Let's look at how these complex posterior cuts overlap. First, you have the thoraco-abdominal. This thing is huge. It literally bridges the thoracic cavity and the abdomen, crossing right over the costal margin. It's used for massive stuff like esophagectomies. Then you've got the lumbotomy and the flank incisions. Notice the huge overlap here. Both are crucial for accessing the kidney. The lumbotomy is a flank cut right in the lumbar region, usually for a nephrectomy. The flank incision itself is positioned laterally below the ribs, also used for taking out a kidney or an adrenal gland. For you, seeing any of these three means standard positioning goes right out the window. Your patient is lateral or prone, and you are diving deep into the retroperitoneal space or chest cavity. So, what does this all mean? When the patient is prepped, the drapes are up, and the surgeon makes that very first cut, will you know what tools they need next? By using Mrs. Graham's guide and really internalizing this whole spatial roadmap, the answer is an absolute yes. You know the doorway, you know the anatomy, and so you know exactly what they need before they even ask. That is how you own your role in the OR. Thanks for joining us for this explainer, and keep mastering that anatomy.